So the first slide is about where health systems are on the left here, where chronic disease self-management are on the right here, and where heart failure management is. Now, when you look on the left here, I was looking through for pictures on chronic disease self-management, and there were so many lots of words and then obviously one or two images. And this is an image here. Now, what's unusual about this image is they're showing older people being happy at the top of a mountain. I suppose that's what maybe is trying to be achieved by chronic disease self-management, is independence in management and independence in quality of life by managing your chronic illness. Now, on the left here is the health system, and the health system comprises many moving components: the healthcare providers, caregivers, healthcare professionals, health systems, patients, and obviously there's a monetary value for all these things. For heart failure, the pyramid starts at the bottom with diet, exercise, lifestyle, symptomatic pharmacotherapy such as diuretics, prognostic pharmacotherapy, which are your beta blockers, angiotensin receptor antagonists, now your ARNIs and also your SGLT2 inhibitors. Moving up from there is device therapies and advanced heart failure therapies, including transplantation. And the cost is obviously escalating for each of these. So heart failure is a chronic disease, and chronic disease account for 85% of primary care separations, but they only receive 15% of the funding, at least here in Australia. Chronic disease self-management programs enhance patient participation. They're cost effective in that they requires minimal funding to execute. Heart failure is an example of a chronic disease. Understanding and improving chronic disease self-management and heart failure should improve lives and reduce costs. A bit about the epidemiology of heart failure. So here's a gentleman who's sitting down. Now, obviously, he was in a sleeping position to get up. So the symptoms they get are shortness of breath on lying flat, and that's because of congestion in the lungs. The pathophysiology is one of a dilated heart. For heart failure, we reduce ejection fraction. So this study does not encapsulate heart failure with preserved ejection fraction. So the syndrome is one of shortness of breath, dependent right-sided features such as swelling of the ankles and of the stomach. It's chronic, it's usually without a cure, and it's lifelong. The etiologies are usually coronary artery disease, diabetes, hypertension, kidney disease, and smoking. So it is a secondary phenomenon from which there is a primary cause. More than 50% of heart failure have a second comorbid condition. The readmission rates are high, between 25 to 15%, and usually this occurs between 1 to 6 months. And readmissions are the largest contributors to cost. The barriers to optimal care are geography, how far you are from medical care, and also isolation. Isolation is not a distance issue, but it's ability of access. So older people are more isolated, even if they don't live very far away. Language, culture, socioeconomic disadvantage, perceptions to health systems, and obviously access to the health system. Chronic disease self-management, the concept has 4 goals. The first is performance mastery, the second modeling, symptom interpretation, and social persuasion. So in a nutshell, basically it's about repeating behavior that you understand to help treat the condition, modeling this behavior around what you know and what has been taught, to be able to persuade family, staff, doctors in conversation, and also interpreting of symptoms. The tasks are medical management, how to manage a medical condition, role management, how to manage being a patient and being well, and obviously disease management and how the disease sits with all the other comorbidities. The 5 skills that are required are problem solving, decision making, resource utilization, forming bonds, and taking action. So problem solving is if you are faced with shortness of breath. It's easy to trigger a phone call and call the ambulance straight away. Alternatively, you can understand what the differentials are, or just a limited amount. Is it serious or is it not? To make a decision to call or not to call, and obviously how much resources you can utilize. The less resources you utilize and use it more efficiently, the better the savings for the system. And forming relationships, and then obviously taking action. The program that we use is the Flinders Program of Chronic Disease Self-Management. Now, this is a 30-page tool. It comes in 4 parts. The first part is a self-management questionnaire. It's called Partners in Health. There's about 12 questions there about self-management abilities. The second part is a Q and response where the health staff explore the feedback provided by the patients and try and see if that is accurate, and then reaching goals and forming a care plan. Other models include the Stanford model. The tool that we have got for this study is called the Screen in Heart Failure. So it's a self-management heart failure tool based on screening heart failure risk and readmissions. So we've managed to make the 30 pages into one page, but also maintain many domains of health screening. It's a binary score rather than an 8 scoring system with the original model. However, it's not been validated. So this is the tool here. As you can see here, the first line of the tool is about readmission risk. Now there are obviously, this is not a perfect tool, that there are obviously things that we need to work on. But with the first domain we cover is readmission risk. And most of the risk scoring systems have comorbid risk, managing your activities of daily, ability to manage your activities of daily living, adequate social supports, compliance, and mood or depression as those things. And we put a score of 1 for each of those points. The second is living at home. So this is specifically about self-management, but instead of having 12 questions, we have put the questions into particular dimensions of care. All right, so one dimension is maintenance, one dimension is management, the other is efficacy. And the questions are just basically very simple. Do you know how to achieve? So that will test your skill and your goal. And in terms of problem solving, decision making, physical function. Second part is, again, do you know what to do if to achieve goals? So it's a skill and goal again, resource utilization, forming patient-provider partnerships, and action planning. And the third part is how confident patients are. And the third domain is about living at home, what services and actions there are for patients who live at home. So the scoring system is probably likely to go into low risk, medium, and high risk. The low and medium risk obviously do not require any urgent attention. So patients will be able to triage from the emergency very quickly. So the high risk patients will require attention in 1 or 2 days, though lower risk patients can probably go to a normal triage pathway. So the aims and rationale of the study is to create a client-focused program that is user-friendly. The 30-page program is not very user-friendly. To link and standardize these to the health channel. So you want it to be able to use across the health channel. So the patient journeys start at home, emergency, ambulance, emergency, ward, discharge, and then community. So all those are opportunities to test self-management skills. And if it's simple to use and is within one page, it's easy to use. And obviously the aim is to address risk and readmission within the emergency department's hospital triage. The patients that most likely to be able to buffer readmission is emergency, ambulance, general practitioners. And the objectives of this study are to validate the one-page tool and improve translational sciences. And by the third point, I mean improve translational sciences. If you look at the way evidence is generated, it goes through phase 0, 1, 2, and 3. So phase 3 is a randomized controlled trial. Whenever you get a randomized controlled trial and it's positive, the p-value is low. It suggests that there's a high chance that that study finding is real. You back that up with another study that's considered solid evidence. So the next step is to translate. Now, to be able to get evidence beyond randomized controlled trials, I mean, it's not possible to do a trial for everything or even for this like in a randomized fashion, because the aim of this is to make sure people comply with their medication. So that means it's already trying to achieve proven care. So you do not need to go through a randomized fashion. But whenever you try and sell this message to bodies is very, very difficult. So I think we need to find methods of improving the ways translational sciences. So if you're finding evidence, which is gold standard to implement versus evidence to translate. So implementation evidence and translational evidence has to be a bit different. So now looking at the heart failure journey of patients, so if you have decompensated heart failure, there's one of three options you can do. You can call your GP on the left here, you can contact the ambulance, or you can go to your specialist. Now, all of these three, usually apart from the specialist, all of these three are usually within the community. Usually within the community. The ambulance, if contacted, goes to the emergency department, gets admitted, discharged in the community. Now, if there is an alternative where the triaging can occur in the community itself, that will be quite beneficial. Now, the question then obviously is, how do you triage something like that? It obviously comes down to readmission risk and risk of patients. Now, biomarkers is certainly one of those things which can be done usually by GPs. Seeing that all those are negative, the second risk is the risk of decompensation at home because you don't have sufficient supports. Now, heart failure programs, you have service domains, and these are usually chronic disease self-management programs, disease management taxonomy, which describes the foundations of each of those services, performance measures with the American Heart Association released 35 for heart failure, and outcomes. And three important outcomes are major adverse cardiac events. These are useful for randomized controlled trials. And for other translational trials, readmission is an important outcome measure, as is improvement in whatever you're trying to test, and in this case, self-efficacy. So the study that we have so far, we have recruited 40 patients with ejection fraction less than 40, following up for 6 to 12 months. We started them on SGLT2 inhibitors. Now, this is the latest medication that's come through. So whenever you start these medications, you know that the patients are of a certain risk. So that is the standardization. They all start this medication and they also require follow-up. So based on starting these medications, we follow them up for 6 to 12 months and obviously use the intervention tools, which is the Flinders model, which is the long 30-page one. And then independently, we will get an independent assessor to use the one-page tool on the information that we have on the patients. We will also complement this with several randomized control systemic reviews. Now, I think this one is not so relevant, just about what the milestones we have achieved. Certainly, we've got the ethics approval and we've started recruiting patients. And it's a summary slide showing heart failure here, living with heart failure on the right, and the goals for chronic congestive heart failure and chronic disease self-management are healthcare costs, cost effectiveness, trying to ensure there's patient ownership and patient participation in health. And those are the references here. Okay, so I hope everyone's got that, but certainly we'll value some feedback from.
Thank you. Are there any questions?
Yes, thank you. It is important and new to say that the patient should help himself and participate in managing himself. In the guidelines, they suggest that a nurse go to the home of the patient to revise his condition, his weight, his compliance. Teaching the patient to do this by himself is good, and this is also similar to rehabilitation programs. So this program, this idea to let the patient treat himself, participate is good and need to be added to the guidelines. Thank you.
Sorry, I also think that patients need to take responsibility for their own health, because if we see in the last year, everything was COVID. So the patients with chronic diseases tends not to go to hospital because of the fear of COVID, and also the hospitals don't treat them. And for me, it's the truth. Take charge of your own health, but teach them, give them the skills to do it, to know when they're in trouble. what signs to look out for and when to call who. And the nurses in the community is very, very important. That is why I normally work in critical care. So I will always work in a curative side. Now I'm actually in a preventative side. And I think we need to really start assisting people to look after themselves and look after their own health before they get to hospital. Sometimes there is not even beds for them to be in the hospital.
Okay, so I think to just reply to Annette's question, I know I just looked up your profile. I think you told me you're working in Saudi Arabia. You're from South Africa, but you're working in Saudi Arabia now. And Mr.
Yes.
Sahir, can I ask where are you from? Are you from Egypt or?
Yes.
Okay.
Yes, from
now.
Egypt.
I don't know how the Saudi system works, but Saudi certainly is a wealthy country and there's a lot of funding. And I know, in fact, my colleague was advising the Saudi government on chronic disease management. Now, obviously, yes. Egypt is a little bit different, the situation, but they have a very strong cardiology network, and both mentioned nurses and going into people's house. Now, I think it's very easy to say, well, that's textbook. And you also say it should be in guidelines, but the American guidelines have actually relegated the self-management from a class 1 to a class 2. So they themselves said there is no evidence. Okay, so you have now a system in a Middle Eastern country with a lot of money, who's able to send a nurse. You have another system in the Middle East where you say nurses are going to go, but there's some fundamental problems. So I think it's very easy. The problem is we all talk about this and we go, yeah, it's easy to do this, we do that. But I'm sure in reality, it must be very difficult for you to do. So that's the fundamental point.
Yeah, actually, in Saudi Arabia, I'm working now for at least 10 years as a head of the cardiac cath lab and the coronary care unit. And I know in Saudi Heart Association, there is subdivision, which is Saudi Heart Failure Association. And they did an excellent job for management of heart failure in all hospital, governmental, National Guard and military hospital. And they are doing an excellent job in the management of care. Also, we have in the kingdom here, the home care system. Home care system, there is a lot of private institution. They are doing home care management, including nurses and doctors, mainly concentrating on the nurses. Heart failure patient, one of this group of patients, they are receiving anti-failure medication at home. But in big hospital, there is a specialized clinic, a specialized unit for treatment of hypertension, like King Faisal Specialized Hospital, King Abdulaziz University Hospital in Jeddah, and in all area of the Saudi, they have an excellent program for heart failure as inpatient and outpatient. And in our institution, we have a clinical pathway for management of heart failure patients, mainly for the inpatient. Still not yet, we are not starting the outpatient clinical pathway as outpatient. But at least there is clear policy and pathway following the guideline directed medical therapy. And we put in all our clinical pathway the medicine which is approved to reduce mortality, as you mentioned, like ARNI or ACE or ARBs, beta blocker, SCGL2 receptor blocker, and spironolactone. And the most important, we are doing screening for the underlying etiology to treat if there is any valvular heart disease or coronary artery disease for revascularization, and if the patient need CRT for failure of medical treatment. But if the patient need any advanced care, we will refer this patient to Prince Sultan Cardiac Center in Riyadh, and they have an excellent center for assisted devices and even heart transplant program. Hello, you can hear me?
I mean, I think it's known. I mean, it definitely is known. I mean, we have a journal there that publishes a lot of this. Yeah, so certainly some areas will be better than others, but it's a difficult area.
Any further questions from the floor? We can go for the next.
Okay.
Okay, thank you.